Good afternoon, everyone. Thank you so much for coming today for the grand rounds. Today I will be doing a walkthrough disorders of mineral bone and bone in chronic kidney disease. So, often our presentations here and in general our practice is shaped by the patients we see in clinic. I think as physicians we are very privileged to do that and see these presentations that help, advance our thinking about many times. In this case, this is a 48-year-old lady, Miss M. I will put her this way. She has a 10-year history of end-stage kidney disease managed with hemodialysis. She presented with the ED due to chest tightness, and she was found to hypertensive emergency. She got an ordered echocardiogram, CT angiogram of the chest and aorta, as well as left heart catheterization due to concerns of coronary events. And looking here already at her CT scan, this is before the contrast was administered. For CTA, you can see multiple calcifications of diffusely descending aorta, and you also see these lesions in her heart. Looking closer at this view, this is essentially the view of the heart on the same CT scan. The orient, this is very posterior, right? This is the aorta down here. This is left atrium. This is a heavily calcified mitral valve between left atrium and left ventricle. We have right heart on the side, and I should just say that she had heavily calcified all four cardiac valves by age of 48, and heavy calcifications throughout her coronaries, but no lesions to intervene. Her chest pain resolved with management of her blood pressure, but Miss M was also found to have dysarthria. This is what her physical exam looked like at that time, which was March of last year. And without giving away what I'm looking at, this is what her exam looked like 10 months later. As you can see, looking at the heart pellet, it was already quite pronounced over a year ago. And you can see how much it was hypertrophied now. Look at the size of the teeth is about the same. So this is not a magnified image. You also see the distance between the teeth has widened on both sides, right? And so did her zygomatic branches. So the disease has progressed. Very, very significant presentation. What did your scan look like? So this is the CT of your face and head, and this is a stock image from the internet, from Science Photography Photo Library. You can see this image here showing a normal heart pellet. It's thin and really well calcified, and on the left is Miss M. So we have widening of the bone, but we don't have enough mineralization. It's very decent. Right, and this is a year ago. This is that milder representation of this. So what this is collapse. This is what they look like. We have about 3.5 years of data for this patient, and every gray bar shows approximately 6 months. The calcium wasn't really that elevated for long periods of time, at least while she was here. Right, we have several episodes of hypercalcemia as defined by Biblio's 10.2 cutoff, but all throughout it wasn't as pronounced. But what was pronounced was her level of PTH. Ever since she presented here for the first time, her PTH was over 1900 on the bottom here on the right, and then why would that be the case? The review of dialysis unit records in town showed that she was not able to tolerate oral calcium or oral activated pipe. This is when she was admitted for parathyroidism. This is her most recent admission. She was administered Parsabiv, so IV calcinometic, with some decrease in her PTH. So and that was mostly to prevent hungry bone disease. She still, unfortunately, got it. So this is her calcium when it drastically dropped, right, following parenteroidectomy. And her PTH level, I think this is very illustrative. Just how fast it decreases. This is within a couple of hours. It went from 3,800 to 200. And it was under 10 people. But it was rechecked again 2 days later. Not in the patient unit. Not every unit, I guess, is fortunate to have easy access. Right. I can say it is not affiliated with you in any way. It is one of the large corporations. All right, so looking at this patient, the big picture outside of facial abnormalities, we see a significant central and peripheral vascular disease, right, throughout your body. And you can see here, we have calcifications, right, of peripheral vascular into your legs as well. And we also see demineralization of the osteoid and the bones overall in this patient as well. So this leads us to the three main aspects of management and looking truly at mineral bone disorders in patients with chronic kidney disease. So we look at abnormalities of PTH, calcium, and phosphate. We look at vascular or other soft tissue calcifications. This is not her, but another representative image. And we'll look at abnormalities of bone turnover, mineralization, and strains. So let's start with the first part. What abnormalities actually lead to high mortality? Why do we worry so much about, for example, PTH and calcium? This is a busy study. And here I can see that at high PTH levels, right, with high calcium and high phosphate levels, we do have significantly higher mortality as shown by this worst plot. So we look at the right side here in these values. Then we look at PTH in the higher ranges. And just to orient you, we have 26,000 patients. In this study, there are 22 groups throughout. And PTH reference range was 15 to 65, which is a typical range between the laboratories. So here, PTH in the upper limit, so 300 to 600, and high calcium, plus minus high phosphate, also resulted in higher mortality. With PTH in the lower range, again, high calcium, and in this case specifically higher phosphate, also resulted in higher mortality. But what is truly pronounced between all of them is higher calcium, right? Which is why CMS is really, truly trying to make sure that the patients in the dialysis units do not have calcium levels that are above 10. As the hallmark of other issues. I also think this is one of the reasons why Ms. M didn't get more proactive management possibly earlier, because she did not have a birth hypercalcemia throughout most of her time on dialysis. So there are benefits and there are unintended consequences of this group. So here, looking at PTH and why it is so important, of course, so that we review for everyone. PTH activates 1-alpha hydroxylase in the kidneys, and we have increased absorption of calcium through the GI tract. We have decreased excretion of calcium through the kidneys. We also have activation of FGF23, which has multiple other effects, including phosphatidylate effects, in addition to PTH. So both of these work to excrete more phosphate out there. FGF23 depends on its co-receptor, called globin. So this factor is a big deal. It is expressed in the distal parts of the kidney tubules, and when the patient is losing nephrons and kidney tubules through the progression of CKD, FLoP2 expression goes down, and that in turn is one of the mechanisms for decreased phosphate excretion. Another part that is important to note is this one, CPP1, CPP2. What are those? So those are the complexes. Calcium phosphate is not soluble, right? It's less soluble than calcium carbonate. It does not float in the blood by itself. It needs a binding protein and it has it. It's between protein, which carries it around. The reason why I'm pointing out these rare or less, I guess, commonly mentioned molecules is because these are therapeutic targets. I will go through some of them as we discuss therapeutics in broad analysis. So here is the progression of CKD. On the x-axis, we will see stages 1 through stages 5 of chronic kidney disease. And on the y-axis, we see either decrease or increase in levels of these factors. So stage 3 chronic kidney disease, we see early increase in FGF23 in red line. And on the black line, we see very early decrease in flow, right? So the loss of kidney tubes decreases these factors as early as stage 3. So late stage 2, early stage 3 chronic kidney disease. Then, as disease progresses, we start to notice rise in PTH. Right, by stage 4, we will see elevation of PTH in many patients. This is the green line, and we also will see a decrease in 125 dihydroxyphosphate. Further, note normal phosphate level in purple. So this is still staying on, and also normal calcium. Right? So those two are the latest, right? The latest lab abnormalities that we will see. And finally, once we transition from stage 4 to stage 5 chronic kidney disease, we start seeing not only the other abnormalities, which are at this point incredibly pronounced, we also see an increase in phosphate and an increase in calcium as an ultimate final abnormality that oftentimes we see when the patient presents to the hospital after progression to end-stage kidney disease for initiation of dialysis. And on the right, these are the same biomarkers that I mentioned on previous and current slide and their utility. For PTH, of course, we can measure it in the lab, and we oftentimes do. So high levels of PTH mean high levels of bone turnover, right? And the other lab that we can check here at UF Shands is BSAP, bone-specific alkaline phosphatase. High level of BSAP also are associated with high bone turnover. Why? Because it helps us distinguish between adenemic bone disease and osteitis fibrosa, or what Ms. L had in our case. What does KDIGO recommend? There are multiple recommendations, right, from KDOKI and KDIGO regarding management of PTH and all the other factors. In CKD, G5D, this is end-stage kidney disease, it's not only for that, for the fellows, we are maintaining intact PTH in the range from 2 to 9 or times the upper normal limits for the assay. And then they suggest that any marked changes in PTH within this range should prompt either change in therapy or initiation. Okay, why is this a big deal? So most labs have upper limit of normal at 65. Right, which gives us the standard range, we all know 150 to 600. UF Shands has a different standard range. It has 12 to 88 picograms per milliliter. And I'll come back to it in the next slide. So our 2 to 9 of upper limit of normal using our assay is slightly different, right, than 150 to 600. And now what does KDIGO recommend us managing high PTH levels with? All the elements we know well, right? We know the combination calcimimetics, calcitriol, or other vitamin D. So when did the assay change? I actually look back, and I'm fortunate enough to have dialysis patients who have been there for 15 years in the dialysis unit. So turns out that somewhere between April and May of 2017, UF Shands has changed from 15 to 65 range to 12 to 88, and we still have that. Oh, phosphate management in chronic kidney disease is one of the hallmarks of PTH management as well. in the patients. It is very multifactorial. First of all, what comes in, right? How much phosphate does the patient consume? And it's approximately 1,000 milligrams daily. And approximately 2/3 will be absorbed. It differs on the origin of phosphate. If that comes from plants, absorption is less. If it comes from prepackaged foods with added phos as a preservative, it's almost entirely absorbed. So what is also important is how much does dialysis bring of phosphate. Turns out it is not bad, but not enough. Hemodialysis removes approximately 800 milligrams per session or 2,400 weekly. PD is comparable. It is less per session. It's only 300 milligrams daily, but a total of 2,100 milligrams. And finally, PTH can act on the kidneys to excrete phosphate even with GFR as low as 3. So preservation of residual kidney function is very, very important in our end-stage kidney disease patients. This is a very busy slide, but these are our dialysis filters that we use here at UF Shands. F160 is the most commonly used one on the inpatient service. This is the phosphate clearance, and again, it's mostly for the fellows here in the room. But if we increase the filter size at the same blood flow rate of 300, it's very clear. We don't increase phosphate clearance that much. What will affect it is if we increase blood flow to 400 and then our clearance with the same filter changes much more than that. And the same is true for the B Brown filters with 19H and 13H. Perfect. So how tightly should we control phosphate in dialysis, pre-dialysis, all patients? So Kidoki in 2011 was saying that phosphate levels should be kept between 3.5 and 5.5. KDIGO in 2009 and especially in 2017 has softened their approach. They say it should be lowered towards the normal level. There is no specifics necessarily, but that is a goal. Get closer to normal. We don't want to be too low, of course, for the safety reasons, yet we don't want to be too high. And what do we treat it with? Well, in adult patients with CKD 3A to 5D, so early stage 3 up until dialysis, receiving phosphate lowering treatment, they suggest restricting calcium-based phosphate binders. So why is that the case? Well, first of all, every patient is their own patient, right? Phosphate does increase, we know, almost universally by stage 5, late stage 4, stage 5, as I showed you earlier. But in some patients, it might happen a little bit. Right. Our current phos binders, what do we have? We have calcium-based binders, and looks like my little speech bubble here is blocking one of them. What it does say is approximately the same things. We have slightly lower pill burden. Sorry, Yvette, I didn't mean to bring that down to take a picture. So we have a lower pill burden. It's easier to chew for the patients. So that, and they taste not bad. Truly, they flavor them with grape, with strawberries. And calcium carbonate and calcium acetate are approximately the same in their efficacy and in their issues. They can all cause calcium overload and other problems with what we talked about. Then we have sevelamer, hydrochloride and carbonate. Main issues, these are large pills that are difficult to swallow, and there are up to 12 of them. So large amount. But they do, sevelamer, both preparations, they do lower LDL cholesterol in addition to other factors. Panthenol, carbonate, is a chewable, easy to take. The problems is that we don't know what happens when it starts accumulating in the bones and how long there's going to be until we see issues. And finally, we have iron-based calcium binders. We have iron citrate and sucroferric oxyhydroxide. Lower pill burden, But as with any oral iron, there are some GI side effects. I think with these medications. Okay, so phosphate binder CKD, this is GFR 20 to 45. So we have mainly stage 3B, stage 4. The binders do, and this is one of those favorite images by Kate Nico. So they do lower phosphate, and this is significant. And among all of the binders between lanthanum, carbonate, sevelamer, and calcium-based binders, the highest level of coronary artery calcification is, of course, calcium-based binders. Here, all-cause mortality, again, pre-dialysis patients, right? CKD stage 4, CKD 5. Sevelamer has lower all-cause mortality as compared to calcium carbonate when looked at through a 3-year long trial. And then we have cardiovascular mortality in hemodialysis, the same first author, the same group, a year later published also, and it's pretty small, right? It's not thousands of people, just about 100, but they did show more cardiovascular mortality in calcium carbonate with Tom's group as compared to silver. Here we have iron citrate or Olesya, so one of the newer drugs, and this is from the website of the company, but it does go along with the published data by the same groups. Olesya is as effective in lowering phosphate as are sevelamer and calcium carbonate. So this is the panel on your left. The panel on your right shows that compared to placebo, Olesya was able to maintain, first of all, lower phosphate and maintain the phosphate lowering over the duration of 56 weeks, just over a year. The adverse effects are diarrhea, so iron preparation, right? 21%, nausea 11%, constipation, vomiting, which I found just probably because of the more pills. Another benefit, though, of iron preparations is that they do help increase your iron. By how much? By approximately 1 gram per deciliter. So Olesya increased 52% of patients compared to 19% of patients on placebo. And this graph on your right just shows progression in hemoglobin level over 16 weeks of treatment. So none of the patients were on ESA or IV iron. All right. And here's the phosphate binders. Now that is an issue, right? How well does that truly work in patients? So high pill burden, GI intolerance, all of those large pills, right? It's hard to take. So they did a controlled study and looked at the patients who were watched essentially and told and monitored to take their pills. And turns out that every week, only half of patients were adherent. And over the entire 8-week period, only 22% of patients were adherent. Right? And these are the study patients. So even the best phosphate binder, if it's not taken, is not going to lower phosphate level in the patient. So how do we address that in the dialysis unit? We address it through empowering both patients and the staff and education. In my case, we are empowering our nutritionists. And what they have done, they not only monitor outcomes and personally report them during our QA meetings. So that is their part, their project, they're the experts. They also show patients pictures. They show not only calcifications, but calciphylaxis, especially in the places where you truly don't want to have it. And it's very graphic pictures, it truly works when you display that. They research new therapies, and they do introduce new medications to the patients. And one of those medications is tenofovir. This is the last one here on the list, comes in dark brown here. This is the use of phosphate lowering medications in our patient dialysis unit. So here we have nearly 50% of patients taking sevelamer. Then we have the group on Velcoro, so iron-based binder, and we have another 5.6% of Olesya issue. This depends on whether our nutritionist did it for the patient, right? from price to negotiating with the company to donate some drug. So very, very proactive management. We have approximately 15% on calcium acetate, which again is limited by patients being not only funded but also on the. But for some of them, we were able to get more advanced medications. We have approximately 4% on TUMS, in addition to something else, in addition to sevelamer, for example. And the new drug, tenapanor exposure, we have 3 patients that we started on that. So what is tenapanor? This is the new medication previously approved for IBS with constipation. So it softens this stool in patients who cannot or do not wish or it doesn't work to take other stool softeners. It inhibits this HME3 in the intestine. Right, so when inhibit protein transport, and that in turn inhibits reabsorption of phosphate back into the blood. The main issue, as you can imagine, is diarrhea. But surprisingly, it's not as pronounced as using iron-based binders. So our 3 patients so far are tolerating it well. No, this is one pill twice a day. You don't take it with meals, you don't need to time it, you don't need to carry it with you, okay? So a bit more convenient. And this is what it looks like. All right. In our summary, so far, we talked that uncontrolled hyperparathyroidism, hypercalcemia, and hyperphosphatemia increase mortality in dialysis patients, and including our patients, and are deleterious in terms of vascular and bone complications. Few option assay for PTH has a different range, and we did usually take it into account in our patient unit when we establish our goals for PTH management. The management of PTH is achieved through a combination of calciumetics, calcitriol or vitamin D analogs, as well as control of hyperphosphatemia, and even the best medications don't work in that. Right, so now it's time to go to the other 2 huge complications and look at the therapeutics for this specific. Okay, blood vessels. Different levels of the blood vessel can get calcified. We have intimal calcifications and we have medial calcifications, right? And these are those calcium phosphate complexes circulating in the blood, CPP1, CPP2 that we were talking about. Also, it is hypothesized that there is differentiation of the progenitor cells or stem cells into bone happening there. And this makes a lot of sense because mesenchymal cells, they have the potential to differentiate either into muscle, including smooth muscle, or cartilage, or bone. So someone is potentiating that transition as well. And of course, there are reactive oxygen species, shear stress, mitochondrial damage, and many other concurrent problems. So here, what does this mean to us? That control of traditional risk factors such as diabetes, LDL cholesterol, or even smoking does not prevent cardiovascular complications in patients with advanced CKD, particularly in dialysis patients. It is not enough. Lower blood pressure targets, aspirin, statins, all those proven interventions, they have less impact on reducing cardiovascular events. But the thought is that net positive calcium and phosphate balance and result in this calcium phosphate hydroxyapatite formation can accelerate calcium deposition in the vessels. And how do we know that? Because even in young adults with end-stage kidney disease, whom traditional risk factors are not yet apparent, coronary and valvular calcifications are very prevalent. So here is the study from year 2000. These are very, very young patients. You can see ages from 0 to 35, right? And in them, starting age 20, the risk of coronary artery calcification scores. Right? This has gone so much, and this is a mix 50% approximately is hemodialysis, 50% is PD. And very diverse population as well. Only 5 were white, only 4 were black, but mainly Hispanic, all kinds of Hispanic patients. The only other risk factor besides of being a little older, right, not under 20 or older than 20, is to be on dialysis for 14 years as compared to 4 years. So longer duration of dialysis and being slightly older, even for very young adults, significantly calcifies coronaries and valves. And this is the study, sevelamer again compared to calcium carbonate. What happens? This is one of the Glenn Chertow's initial earlier publications in 2002. Sevelamer is in black, and calcium acetate is in gray. We see much less coronary artery calcifications. The patient was before and aortic calcification is also significantly reduced. So black bars compared to gray bars. Oh, wait. So what else can we do? Can we do magnesium, right? Can we give patients magnesium hydroxide, like this study did that was published last year? And these are pre-dialysis patients, right? We have GFR here of 15 to 40. What if we start feeding them or treating them with magnesium hydroxide? So 50% of those on magnesium hydroxide develop it, which is unfortunately excluded. Having said that, there is no, and there is no real change between coronary calcium scores. So this is not something that we can do to prevent calcification of the coronary arteries. And what I think is also very important here is that they checked urinary magnesium. It was high. They checked serum magnesium. It was higher, right? So the patients were taking it. Adherence was 97%. So unlike phosphorus, they actually work in terms of adherence. It's just that therapeutics is your priority. And this is the effect of magnesium supplementation on vascular calcifications of hemodialysis. This is the first plot. And this is a meta-analysis of multiple trials. And you can see, usually when something favors it, they put it on the right. Here it's the opposite. So this is control. This is no increase in magnesium in dialysis. They do better. There's no real, or unchanged, essentially unchanged. So we call it 0. There is no improvement in calcifications in dialysis patients with increased magnesium, which is different from animal studies. Another medication that just got FDA approved as an orphan drug for these calcifications, right, is SN Smith 472. It's myoinositol hexaphosphate, so it inhibits formation and growth of hydroxyapatite. So these calcium phosphate molecules, it inhibits their growth. And it looks like coronary artery calcium volume was decreased. And is 77.32, as you can see here, it is significant. And we have both coronary arteries and aortic valve calcifications. And now this drug is also being studied for calciphylaxis. I believe it's going to stage 3 clinical trials at this point for calciphylaxis. So Semfit, I think, is going to be the name that we will be more familiar with soon. Right, bone disease and more excursion, right? Mineral bone disease. Disorders. Alkaline environment promotes deposition of new bone, so action of osteoblasts and formation of osteocytes in lining, and acidic environment promotes resorption of the bone and action of osteoblasts. PTH acts on osteoblasts and the new osteocytes. Osteocytes are essentially osteoblasts that get stuck here in the cement of the lung. And they're still active cells, but they are not whole back. And then indirectly, PTH also works on osteoclasts and new osteocytes. At the same time, 125 dihydroxyvitamin D works on mineralization of osteoid. So that is when the new osteoblasts get flattened and calcified. information that osteoid, which is so thinned, it was very thin in Miss M, it is thinned in all of the dialysis patients and late stage CKD patients. So let's say pre-dialysis. How is this important in terms of lung fragility? So this is what we saw in Miss M, right? We have more of this originally. And CKD and aging both promote bone resorption and cortical thinning and increased cortical velocity. Osteopenia and osteoporosis, if they're diagnosed by DEXA, they cannot distinguish between high or low bone turnover. So they don't really help us which therapy to choose in our advanced CKD patients. Well, they say that something needs to be done. In CKD 3B to stage 5, there's a 6-fold increased risk of hip fracture. And this is compared to patients with normal gene fracture. And those who are older than 75 have 2-fold increased risk in mortality compared to those who don't have CKD, right? They already have high mortality risk. So how do we diagnose it? Of course, laboratory testing. So calcium phosphate PTH, more than those 9 upper limits of normal, is 86, very specific. So 86% who were high turnover disease. And BSEP, more than 42, if it's high, it also excludes head and neck disease. So it excludes lung turnover. But this is why we have both of these tests as chance, and they together can help us guide the therapy. If PTH alone with them. Should we do a test? Right? Should we do a bone biopsy? If we're not sure, right? If PTH is intermediate, if BSEP is intermediate. So what does KDIGO say? KDIGO says that in patients with CKD 3A to stage 5D, so through dialysis, they do suggest bone mineral density testing to assess fracture risk. And green is because that's how they publish it. They publish it in green. For the new update from 2009. Well, what does European consensus statement say from 2021? This is more than 7 years ago. So CKD patients over age of 50 or those who had prior fragility fracture, they don't need DEXA, right? Treat them without DEXA. Bone biopsy. So KDIGO says that, yes, it is reasonable to perform the biopsy if knowledge of the biopsy results will affect our treatment decisions. So nice and late standard statement. What are the limited to the bone biopsies? Usually by the experience of the center. Most centers cannot probably fix the sample and properly interpret it. UCSD can, and I will go through their experience. But overall, if you can't process it and send it out, okay. So now we see who is more likely to have a fracture. So we have this study, almost 35,000 patients, almost 500 of them with hip or other fractures. And those, those are typical patients, regardless of CKD, older women, lower BMI, so smaller, older women, and mostly white in North America, but this is necessarily in other places. Those with more years on dialysis, higher PTHs and KTOs, higher comorbidity burden, and prior hip fracture. Here on the right, you see it's not quite a forest plot, but it's a rate of death per 1,000 of patients. So this is, in the middle is 500 per 1,000, right? So this is half. Half of the patients will die if they get a fracture. So this is very, very, very big, right? The green is the ones who didn't get a fracture. The blue and purple, different analyses for those who did get fractures. So who are these patients? Of course, the older they get, the more likely they are to pass away after having a fracture. And those who have cardiovascular disease are more likely to pass away compared to their peers who didn't get the fracture at the same age with the same disease. And African American patients. Not the white ones who are more likely to get fractured, but African Americans. Okay, these are different centers around the world. And what happens here? two blue lines, just pay attention to those two. This is Japan. Nothing bad happens, right? There's a slightly decreased, slightly decreased survival in Japanese patients with infection. But as dramatic as, for example, for North America or Europe. Right here we have 3.7 times increase in risk of mortality. They also have a 30-day hospitalizations here in Japan, based on anxiety. All right. The most common causes of death were either cardiovascular events or infections. So number 1 and number 2. All right, so how do you manage for bone specific things, right? We already managed our PTH, and pulse looks okay, and calcium is not too high. So there are different molecules, bisphosphonates, namely oral alendronate, that is hard to swallow, physically hard to swallow, and the IV pamidronate, one that we sometimes use here in some rare patient cases. If it is given in patients for advanced CKD, there's a chance of progression of their kidney disease. It's not quite clear why. I do, this is completely off label. I do like denosumab, but I like it in patients who don't have CKD. If you do have CKD and if you've ever seen it given, it decreases calcium for weeks. You chase that low calcium and risk all the cardiovascular arrhythmias during that time. It is very, very important in decreasing in lowering calcium to the scary level. Other things, so yes, we can do hormonal therapies, teriparatide, for example, right? Greensbell, for example, breast cancer patients can be used, and UCSD uses that in combination with alendronate. All right, cinacalcet. Yeah, it does help a little bit with bone strength, and it does decrease mortality a little bit. It's not significant, it's a trend. This is New England Journal of Medicine publication. How about its IV cousin, the Percival, calcitide? Essentially the same. Here they did not look at mortality. They looked at the quality of bone, and they did see about 10% increase in bone scores in the patients, and they did see increased mineral density, which I think is an improvement. Overall, KDIGO's stance is to use calcium mimetics if we are concerned for osteoporosis in these patients. All right, so this is the experience of Dr. X, who's a division chief at UC San Diego, and published this article. What they do, they get DEXA on their dialysis patients every 2 years. And if they see worsening osteoporosis or fractures, they look at PTH and VSAC. If those are conclusive, they go ahead and manage them with, or adjust management for PTH reference ranges. If unconclusive, they go for kidney biopsy, which is available at their center. And they do initiate this low dose oral bisphosphonate, so alendronate, and apparently they have good success. I don't know if it will become standard practice or not. I have a feeling that KDIGO guidelines for 2017 will be updated sometime soon. I don't have exciting information. All right. So far, we have illustrated the different manifestations and mechanisms for mineral bone disorders in chronic kidney disease. We identified current guidelines and landmark trials for management of our biochemical abnormalities and vascular calcifications and bone disease. And we discussed new updates in therapeutics. In my conclusions, and I'm very fast today because I'm really good. Uncontrolled hyperparathyroidism, hypercalcemia, and hyperphosphatemia increase mortality in dialysis patients, and they're deleterious in terms of vascular and bone complications. This is the study of this is the calciphylaxis trial for this SNF for 7-2 drug.